So mainly just going to concentrate on the list on the left, acute appendicitis, acute diverticulitis, pancreatitis, epipleural appendicitis, bowel obstruction, ischemia, perforated viscuses, and aneurysmal rupture. And then the list on the right, I'm sure, is going to be covered by other speakers during the meeting. So the objectives are to review the important, common, and mini causes of the acute abdomen with an emphasis on CT, and review the associated information that can come up in a discussion with clinicians or referrers, etc. So, role of imaging by modality. In North America, CT is the primary modality for evaluating the acute abdomen. Ultrasound obviously has a role, mainly to evaluate the gallbladder or obstructive causes. And probably in Europe, appendicitis may be evaluated by ultrasound. And abdominal X-ray, obviously, a very limited role. And again, MRI, mainly for problem solving. So I've kind of got cases interlaced in the talk just to keep you awake. And so the first case, obviously, I'm sure no one will have any problems in making the diagnosis. So just some inflammation in the right iliac fossa. There's a structure. This isn't contrast. This is the appendix, and this is an appendicolith. So diagnosis of acute appendicitis. If only it was always as easy as that. So CT signs of acute appendicitis. So we're looking for the diameter of the appendix to be greater than 6 millimeters, but that's not it's not a sort of panacea. So sometimes we can obviously have an appendix bigger than 6 millimeters, and it's not acute appendicitis. So we've got to look for good associated history, and then other supporting evidence. So fat strandings it's a very useful sign. Obviously, in this case, we have a lot of inflammation, a lot of stranding. So obviously, if you see an enlarged appendix with associated fat stranding, you're kind of home and dry, and it's acute appendicitis. Sometimes we may not get fat stranding, and so in that kind of situation, we're looking for other supporting evidence. If you have associated thickening of the adjacent structures, particularly the cecum. You've seen appendicolith. Obviously, you can have an appendicolith in the non-appendicitis appendix. Fluid in the paracolic gutter, fascial thickening, sentinel bowel loops, probably a more useful kind of plain film sign, and reactive lymphadenopathy. So, let's look at some of the pitfalls for enlargement of the appendix without secondary signs of inflammation. So the appendix, multiple studies have looked at this. So the appendix, if it's greater than 9 millimeters, only about 50% of those will have appendicitis if there's no associated signs or not a good history. So don't, just because the appendix is a little big, don't automatically think appendicitis. I mean, here, we have a slightly big appendix. And a lot of those studies, the studies were performed without contrast, so that kind of makes it harder to assess the true size of the appendix. There may be fluid in there. And again, 40% of the normal empty appendices may be greater than 6 millimeters. So again, size is not the be-all and end-all. However, if the appendix is less than 6 millimeters, there's virtually no chance of that person having appendicitis. So again, we're looking for airless or low attenuation fluid in the lumen is worrisome. But again, if you see an appendix, it doesn't necessarily mean if the appendix has no air in that they definitely have acute appendicitis. So again, that's not it's not a sort of definitive finding. So API, again, if we don't see the appendix, that has a very high negative predictive value. So only about 2% of patients where we didn't see the appendix on CT, usually those are going to be thin patients, end up having acute appendicitis. So there's very high negative predictive value. So sometimes, findings may be indeterminate, and in that situation, it's valid to put in your report indeterminate. Maybe it's a very early appendicitis, and in that situation, often we'll do follow-up imaging within 28 to 48 hours if the symptoms don't resolve. So here in this acute abdomen in pregnancy, so what do we see? Obviously, we see this pregnant uterus, there's some fluid there. So this is a situation where we may go to do MR, and this was the appendix here. We see some, very similar to the CT appearance, but obviously on MR. We can see some interstitial, some fat stranding there. So there's, again, diagnosis of acute appendicitis on MRI. How about this case? So one of the great advantages of CT, you can see in this case this person has malrotation. So it's very useful to find the ileocecal valve. There's the ileocecal valve. We don't actually see the TI. And there's a lot of stranding here in the, in the vicinity of the ileocecal valve, but it's a very abnormal location for acute appendicitis. Again, this patient had acute appendicitis, so I don't see the appendix on this particular slice because it was difficult to get that on with the colon and the ileocecal valve. So again, if you see abnormal or sort of malrotation of bowel, it doesn't exclude the diagnosis of the appendix if the inflammation is in a kind of remote or unusual location. How about this case? Crury appendicitis. So we see the appendix. It looks dilated, lots of fat stranding of the surrounding tissue. But we have a lot of almost disproportionate thickening of the cecum. So in that situation, we'd include in our diagnosis cecal diverticulus, inflammatory bowel disease, infections such as TB, Yersinia, some other organisms. But unusually in this case, this one actually was acute appendicitis, probably disproportionate thickening in the cecum. Obviously, usually we don't see it as thickened as this. It's just often the medial side. But again, if you have a markedly inflamed appendix, lots of stranding in the right iliac fossa, even if some of the other signs don't entirely fit, obviously we're not going to exclude that as a diagnosis. So how about ultrasound? So the ultrasound criteria for non-compressible blind ending appendix of greater than 6 millimeters, very high specificity. So the 6 millimeter size of the appendix obviously comes from the ultrasound literature, and in ultrasound they can compress down on the appendix, so they can get it down to, if it's more than 6 millimeters, then that's probably a true size of the appendix. So this obviously, if the appendix is larger than 6 millimeters, then that is very specific. If you find it, it's much harder to find the appendix under ultrasound. So some other ultrasound criteria of appendicitis: non-compressible, blind ending tubular structure greater than 6 millimeters. So you see this tubular structure is like 9 millimeters. Echogenic, maybe have shadowing foci within the lumen. Could be the appendicolith, increased vascularity when you put on the Doppler. And the limitations, the obesity, if it's retrocecal or if it's perforated, then it's going to be hard to identify the tubular structure. And then false positives, you could obviously easily mistake, particularly in the uninitiated hands, the small bowel for being the appendix. So you want to find the tip of the appendix and see that it's a blind ending structure, again, to be definitive that it is the appendix that you're identifying. And again, if we have advanced appendicitis, can make the diagnosis quite tricky. Here we have an appendicolith to kind of guide us, but you can have lots of stranding and collections where we see the appendix here is inflamed to help, but that can obviously complicate the diagnosis. So CT of complicated perforated appendicitis, we're looking for abscesses or inflammatory masses or phlegmons. And if you find a defect in the enhancing wall here, we're showing a little defect that can help with the diagnosis of perforation. Again, if there's intraluminal or extraluminal air, that can also help in the diagnosis. And extraluminal appendicolith, very, very high specificity, but I haven't seen an extraluminal appendicolith yet. But if you see one, that's obviously very, very specific for perforated acute appendicitis. So moving on, case 2. Again, what do you think this is? So we have some inflammation. We're down in the pelvis. We see it's a sigmoid colon, multiple diverticular marks, soft tissue stranding, little collection there. So I'm sure none of you have any problems with this. Case of acute perforated diverticulitis. So about 25% of patients with diverticulosis may develop, they have a lifetime risk of getting acute diverticulitis. Again, we're looking for colonic wall thickening in the sort of 7 to 10 millimeter range. Pericolic fat infiltration, we see extensive fat infiltration. Inflamed diverticulum, so if you see a focal diverticulum that's particularly inflamed, that can be very high specificity for diagnosing acute diverticulitis. Pericolic or distant abscesses, extraluminal air fluid, or again, fistula or obstruction of the bowel. So acute diverticulitis or complicated diverticulitis, well known for fistulization. Here we have a colovesical fistula, or here's another example of an intracutaneous fistula. So it can be very nasty, aggressive disease, particularly if it fistulates. So important points to mention to the clinician: CT is not useful in differentiating cancer from acute diverticulitis, so I'm sure most of us still include that in our reports. Maybe needs a follow-up contrast enema or endoscopy, and the practice parameters of the American Society of Colon and Rectal Surgeons still advocate that. And obviously we want to avoid that in the active acute diverticulitis because of the risk of perforation. So here's microperforated colon cancer. So again, very difficult diagnosis to differentiate that from acute diverticulitis, particularly in the sort of early setting of the disease. And here, one example is acute diverticulitis. The other one is a microperforated colon cancer. And if I was a betting man, I'd say this was probably the cancer, but it could be you could easily go for the either one. Okay, case 3, 50-year-old patient with acute epigastric pain and tenderness. Let's just scroll through the data set. We see an extensive amount of fluid in the retroperitoneum, in the region of the pancreas. Pancreatic tissue appears edematous and is poorly enhancing. So that was diagnosis of acute pancreatitis. So the imaging of acute pancreatitis, common causes are going to be idiopathic pancreatitis, gallstones, alcohol, and the sort of descriptive terms that we use have changed recently. There's been the Atlanta classification is the sort of newest thing that we use to. So the terminology that they use is interstitial edematous pancreatitis, and that's what we see in the setting of mild pancreatitis, and makes up about 80% of cases. Can have a normal CT. So again, you can have pancreatitis, obviously, and we may not see the CT features of it. However, if we see focal or diffuse enlargement or peripancreatic fluid, that can obviously help in making the diagnosis. Ultrasound and MR have a sort of a limited role in the acute setting. Ultrasound, again, early on, maybe looking for gallstones, and MR later on, looking for pancreatic divisum or some other potential causes of the acute pancreatitis. So complicated pancreatitis, new terminology, again on the Atlanta classification, is necrotizing pancreatitis. This can make up about 20% of patients, and these definitely have abnormal CTs. We're looking for pancreatic necrosis, extensive peripancreatic fluid or collections, pseudocysts. So here we see extensive peripancreatic fluid, poor enhancement of this area of the tail may represent necrosis, and then other complications such as pseudoaneurysms, venous thrombosis. And again, patients can be difficult to make the diagnosis, particularly if they have underlying chronic pancreatitis with extensive calcification and ductal dilation. Those patients don't get acute inflammation, but doesn't. So we have to be more careful with those particular cases in establishing the diagnosis. So here we see a pseudoaneurysm often affect the GDA or the splenic artery, and again here we see extensive inflammation of the pancreas, markedly compressing the splenic vein, SMV area, and you can understand why these patients may go on to thrombose those vessels. So moving on, carrying on with acute necrotizing pancreatitis may affect 20% of cases, much severer disease, results in organ failure. CT, the hallmark is necrosis, and so we're looking for well-defined areas of non-enhancement greater than 3 centimeters or affecting more than 30% of the pancreatic volume. And so again, the terminology we're using now is acute necrotic collections or pseudocysts. Less likely, it's the kind of preferred thing is not to call them abscesses, and that's based on the Atlanta classification. So other criteria you may look at is the Ranson criteria or the Apache score to assess the sort of clinical significance of the disease in a particular patient. So some pearls for pancreatitis. There's no single serological test is pathognomonic. Again, we look at serum amylase or lipase based on the Atlanta criteria. If those are elevated by 3 times normal, again, that's very highly suspicious for acute pancreatitis. We're looking for acute fluid collections. So, early on, you may get peripancreatic collections. After 4 weeks, if there's a persistent collection, that's when we call it a pseudocyst. And also maybe extensive extrapancreatic inflammation and also peripancreatic necrosis, again, from the pancreatic juices kind of oozing out into the surrounding tissue, or you may have hemorrhagic pancreatitis if there's high-density material in the surrounding tissues, another diagnosis to make. So again, supportive treatment if there's no infection is the main way to treat these patients. And as regards to the collections, we want to differentiate them. So in the early stage, we probably will describe them as acute peripancreatic collections. If the collection persists or it looks more complex, then the terminology we want to use now is acute necrotic collections rather than abscess. So here we see this very little pockets of gas. So and it's kind of walled off. So acute necrotic collection, and that may have like pits of necrotic pancreas or other necrotic tissue within there, and often those require large bore drains to drain those collections. And if it's a more simple type of collection that's persisted for more than 4 weeks, then pseudocyst is the terminology, but the mortality is much higher for these necrotic type collections. So moving on, case 4, 56-year-old woman with left lower quadrant pain and fever. So what do we see? So here's the descending colon, and we see this fatty structure with some inflammation. And the diagnosis is epiploic appendicitis. So often, as radiologists, we're well aware of this diagnosis, but often I find in clinical practice, you often have to explain to the ED docs what it is and that it's not appendicitis, but it's these epiploic appendiger. And so presumably due to torsion or ischemia, so here we can see this nice pool of ascites, and we can see these epiploic appendages. And so thought to be, the patient's developed either idiopathic or some form of vigorous exercise. Who knows what kind of exercise that was? Probably jumping up and down or, trampolining or something else. And these patients may present with mild pain, fever or leukocytosis, and can mimic appendicitis clinically or diverticulitis. And if you're not aware of the diagnosis, obviously, the patient, that may be the diagnosis the patient ends up with, particularly diverticulitis. And but it's important to remember the epiploic appendicitis. So here, on CT, it's a CT diagnosis. We're looking for ovoid pericolonic fat. So we're looking for this ovoid structure with central high density dot within it. And usually, most commonly seen in the rectosigmoid, where most of the epiploa are. The differential diagnosis is a mental infarct. Those are classically bigger and more likely to be in the right upper quadrant. And another potential pitfall is groin hernia plugs. This was described by one of my colleagues, Dr. Beignet. So particularly in the sort of iliac fossa area, the clinicians use these hernia plugs that are a bit like umbrellas, and there's the sheet, but you can see the fat collects up behind it, so it can be mistaken for something else, particularly epiploic appendicitis. So if there's if you see this in this area, it's important to get a history from the clinician if they've had a recent hernia repair. So that would be that would just be a normal finding in someone who's had a hernia repair. Another example of epiploic appendicitis, again, we see this fatty mass with extensive stranding, mainly surrounding the mass. And you look at the adjacent bowel, not that you may get a little bit of secondary inflammation, but not that inflamed around it. Here's some examples of old epiploa. They're just calcified, and again, nothing to be concerned about. So here's a plain radiograph, and it just shows how little useful information we can get from plain radiographs. So obviously, if they're positive, then that's helpful, but if there's nothing to see, then that doesn't help us very much. So what's the next step? And we're going to do a CT. So that was the radiograph for this patient, and no problem making the diagnosis of this. Markedly dilated loops of small bowel, and as we scroll through it, we can see some decompressed loops distally. So if we just go back, okay. Well, there was a lead point. We're looking for a transition point there, and here's another example with a transition point from dilated bowel to decompressed bowel. So we're looking for dilated bowel proximally with collapsed bowel distally to make the diagnosis of obstruction. Proximal bowel usually dilated more than 2.5 centimeters, distal bowel less than 1 centimeter. And if we see feces or gas in the proximal bowel, so consistent with small bowel feces sign or stasis, doesn't always mean that the person's obstructed. Usually means there's abnormal motility in that bit of bowel. So, but it just means look more carefully in that location for an abnormality. Often we don't find a specific cause, and in those patients, usually the diagnosis is adhesions, and that makes up about 70% of small bowel obstructions. So common causes of obstruction, major causes of SBO, adhesions, malignancy, inflammatory bowel disease, hernia. So any kind of acute or chronic intra-abdominal process, interception, and the large bowel, often that's related to colorectal carcinoma or volvulus. Again, interception or hernia, maybe other potential causes of obstruction. Here's another case. 25-year-old patient with pain and vomiting. So we see dilated loops of bowel. We see this big, thickened bit of bowel here. Looks a bit like a pseudokidney. And we see this abnormal piece of abnormal bony lesion. And the diagnosis here was SBO by intersuscepting metastasis. Obviously not something we see every day. And this was bowel-in-bowel sign of intersusception with calcified lead point metastasis from osteosarcoma. So this was like hyperdense even on the pre-contrast images. Maybe either this is the primary site or another site of bony metastasis in this patient with osteosarcoma. So adult small bowel interception only affects about 5% of adults, usually a pediatric diagnosis, and I'm sure the pediatric radiologist will be covering this. More likely subacute or chronic symptoms. Majority have an underlying cause or lead point, and resection is treated. Often these patients may have some mass or etc. causing the interception. Again, on CT, we see this all the time virtually. Short interceptions may be self-limiting. And again, just analyze that area, make sure there isn't an associated mass and the bowel looks fine. That patient, that resolved 5 minutes later. There's no associated mass in that patient. So in comparison to pediatric interception, 95% of interception cases are in the pediatric population. 80 to 90% of pediatric bowel obstruction due to interception, mostly due to lymphoid hyperplasia, treated by pneumatic reduction, and is a common cause of acute abdomen in children. Again, appendicitis is the most commonest cause, but interception is second again, and it's a slightly younger age group in children. So tips for CT of bowel obstruction, we're looking for dilated bowel, collapsed bowel distally, helps us to distinguish from ileus or dysmotility syndromes. And also finding, again, we want to find the exact transition point. Can be difficult, so we're looking for a mass or hernia or interception. And we want to assess the bowel to make sure there's no evidence of perforation or strangulation. So those are the key things that we want to exclude. And here's some examples of strangulated SBO. You see dilated loops of bowel proximally upstream, some with contrast, some without contrast. And then when we get distally, this patient had IV contrast. We see, we can actually make out the wall relatively well in some of the more proximal loops. Down here, the bowel wall becomes very indistinct. So this has been well described as a disappearing bowel wall sign. There's a lot of fluid, and so we'd be concerned about the vascular viability of this segment of small bowel. Another example, patient with strangulated SBO, we see infarcted, dead loops of small bowel from the OR images. And again, we see nicely enhancing loops of bowel. Here it becomes a bit more indistinct, and we get some mesenteric infiltration extending up into the small bowel mesentery, all very suggestive of strangulation. So just recap, strangulated ischemic bowel and obstruction. Always look for warning signs when the bowel is dilated, if there's excessive fluid, mesenteric infiltration or mural non-enhancement, disappearing bowel wall sign. Here's another example. We can see the bowel wall enhancing nicely here, and then it becomes much more indistinct later on in these later loops. Very, very concerning for ischemia or infarction. Less helpful signs are dilation. Obviously, there could be a lot of causes of dilation. Bowel wall thickening, again, other inflammatory causes. And pneumatosis obviously could be related to ischemia, but can be seen in other associated conditions. So this patient with abdominal pain and vomiting, what do we think the diagnosis is? We see some dilated loops of bowel here, and then we see some more decompressed loops of bowel distally. And these loops of bowel here look like a bunch of balloons on a string. That may help us in establishing the diagnosis if we weren't sure. And so this is kind of on the spectrum of closed loop obstruction, where we're looking for segments of bowel that are occluded at 2 points. And the bowel meets at one single point. Often the cause is adhesions, internal hernia, small bowel volvulus. And classically we look for a U-shaped dilated loop of bowel if it's just one focal loop of bowel with distal decompression. On the axial images we may get a beak or a whirl sign as the mesentery is kind of whirling around this twist. And if they're clustering, we get this balloon on a string appearance. And again, these patients have high rates of strangulation or ischemia or infarction. This is illustrated in a closed loop. Here's the more proximal bit of bowel coming in. This is the closed loop, which is twisted around, and then it's decompressed later on. And in this area here, in the twist, we see the whirl sign of the mesentery. Some other causes of a small bowel obstruction would be secondary to herniation. 95% of these are going to be due to external hernias, inguinal, femoral, or umbilical or incisional hernias. 5% would be internal hernias, paraduodenal, epiploic foramen, or diaphragmatic hernias. And 28% of SBOs may be complicated by strangulation or ischemia. Again, we try to avoid using the term incarcerated. That's a clinical diagnosis of non-decompression of some focal loops of bowel that can't be decompressed by clinical manipulation. Case 8, 68-year-old man with acute abdominal pain, vomiting, and anemia. And what do we see here? We see this sort of dilated loops of bowel. Looks like large bowel. There's some stool in there, and then we have this thickened area here, and then more decompressed distally. So this was obstructing colon cancer and cause of large bowel obstruction. So large bowel obstruction, much less common than SBO, often due to colon cancer, maybe gradual in onset. Again, most commonly seen in the rectosigmoid. Colon cancer is obviously most common in the rectosigmoid, more likely to obstruct. Can be occasionally be due to diverticular disease or volvulus. And so moving on to other causes of acute abdomen, case 9, acute upper abdominal pain and vomiting. We have some images of the stomach. We have this little focal area of fluid, appears to be in the gastric wall there. Much better appreciated on the coronal images. We see marked thickening of the gastric wall in the pylorus region, and this is a peptic ulcer. So gastric ulcer, perforation, peptic ulcer disease may be difficult to recognize. We're looking for, particularly on CT, we're looking for gastric wall thickening, edema, free air if it's perforated, infiltration of fat or adjacent organs. It can cause gastric outlet obstruction. And again, we're looking for areas of leak, maybe due to infarction, ulcerating tumors, inflammatory bowel disease, or ingestion of foreign bodies. This was a malignant gastric ulcer, so we see more heaped up margins, marked thickening here on the CT compared to the rest of the stomach. And this again had perforated. We see gas on both sides of the outside of the stomach wall. So moving on, case 10, patient with known abdominal aortic aneurysm and increased abdominal pain. What could the diagnosis be? So here we see large, dilated, aneurysmal aorta with some calcification, and we see this hyperdense material in the retroperitoneum. We gave contrast, and so this was a case of leaking abdominal aortic aneurysm, and we don't see any active axtrav in this case, but there's no doubt about the diagnosis. So CT of ruptured AAA. We're looking for extraluminal retroperitoneal blood, which we have in this case. Focal disruption of the calcified aortic wall. So you want to go around the wall, particularly if you have a previous CT, is very helpful to compare the two if there's an area where the calcium is disrupted. Active extravasation. In this case, we do have active extravasation to aid us in the diagnosis. And we can get sort of false negatives, which could be small contained ruptures. So here, if we just had the non-con CT, sometimes these patients obviously just get non-con CT. Can be difficult to make the diagnosis, but it's important to look all around the lumen. And here was the focal small contained rupture, or was contained and then become uncontained. And Other things would be false positives such as perianeurysmal inflammation, lymphadenopathy, or saccular aneurysms. So ruptured aortic aneurysm, risk of rupture within 5 years by size. Again, as these things increase, the risk of rupture increases significantly. If it's over 7 centimeters, 75% risk of rupture. Very high mortality, as many as 2/3. Patients die before reaching the hospital. 50% of mortality even if they reach hospital, if they've ruptured acutely. So CT of impending rupture, we're looking for the crescent sign. It's much easier to appreciate on non-con CT. This represents intramural hematoma, so either hemorrhage or the vasa vasorum in the media of the aorta, or can be dissection into the media, and strongly correlates with impending rupture. Often these patients are symptomatic when they have this sign, with pain in the region of the aorta. So findings predictive of impending rupture: hyperattenuating crescent sign, increased aneurysmal size on serial imaging, a rate of greater than 10 millimeters or more per year, a very large abdominal aortic aneurysm, more than 7 centimeters. If there's reduced thrombus, intramural thrombus in relation to the size of the aneurysm, again, that's consistent with rapid expansion and also a sign of impending rupture, or discontinuity in the calcification. These are all signs of impending rupture, impending doom. And some pitfalls: periaortic soft tissue. Often, we get retroperitoneal fibrosis or lymphadenopathy, and these patients may have other associated signs. We can see the actual aortic lumen there. We see calcification of the wall. The aorta is not aneurysmal in this case, despite all this extensive soft tissue around there. And this patient also has hydronephrosis. So moving on, case 11, 80-year-old with severe abdominal pain and distension. What do we see? We see some pneumobilia. We've got lung windows here. We see dilated loops of bowel, and we see some evidence of pneumatosis within the bowel wall, and a little bit of gas there within some of the draining veins. Again, helping us to reach the diagnosis of CT in setting of bowel ischemia. We're looking for pneumatosis, maybe in the distribution of the SMA, celiac, or IMA, particularly the IMA, and looking for mesenteric. Could be artery or vein abnormalities, or you can get venous infarction. The bowel walls thicken, greater than 3 millimeters, venous air, and again, lack of bowel enhancement, as we mentioned earlier. And often these patients may have other areas. If they had an embolic event, other organs may be infarcted. So acute mesenteric intestinal ischemia, abdominal pain with one or more of the associated findings. The pain may be disproportionate to the clinical findings. Biochemical evidence of ischemia, lactic acidosis, associated risk factors such as atrial fibrillation may mimic other acute abdominal processes. Very high mortality, so it's important to recognize early. Usually arterial thrombus or embolus. Again, CT of bowel ischemia. This patient has dilated bowel, has poor enhancement. We can see infarcted kidney there, probably had embolus to the other organs as well as the bowel itself. And in this case, we had SMV thrombosis as the cause of, so venous cause of infarction. So colonic ischemia, not typical. We have vaso-occlusive, rarely transmural infarction, vasoconstriction from low flow hypertension, and we have particularly affects the distal left colon, the IMA distribution, or can be in these watershed areas around the sort of splenic flexure. But appearance is non-specific, and endoscopy may be required to make the diagnosis. So again, with chronic ischemia, not typically vaso-occlusive. Rarely is it transmural infarction. May just affect part of the bowel mucosa. You may get vasoconstriction, either from low flow or hypertension. Again, particularly affects the distal left colon and the IMA distribution. And again, appearances may be non-specific, and endoscopy sometimes can be helpful in making the diagnosis. So just to finish off, just a conclusion. So take-home points. CT is the backbone for the acute abdomen, and acute abdomen cases are sort of high-stake cases, important. We make the diagnosis. Often these patients are critically unwell, and it's important to focus on the most common diseases to make the diagnosis or exclude causes, and particularly vascular causes such as ruptured aneurysm, mesenteric ischemia, or causes of bowel obstruction from closed-loop obstruction.